Good morning, all. I am Dr. Saramma Mathew Fenn from the Department of Oral Medicine and Radiology, and I'm here to discuss for today's topic is about periapical radiolucencies. This topic will be covered under the following headings. To ensure the understanding of this topic, few terms are to be learned as to know what is radiolucency is, where is the location of this radiolucency, whether it's pericoronal or periapical, and to know the appearance of this radiolucency, whether it is unilocular or multilocular in a radiograph. The radiological examination is the most important investigatory method to evaluate any lesions of the jaws and teeth. These bony changes are due to the osteoclastic changes seen at the apex of the tooth. So hence the name, it is known as periapical radiolucencies. And however, these pathologies are to be differentiated from the tooth associated or from any other diseases or systemic diseases which causes this radiolucency are to be ruled out for efficient diagnosis. Hence, these radiolucencies are classified based on their etiology as either pulpal origin or true periapical radiolucencies, and it can be also classified as non-pulpal origin and in terms of rarities. The tooth-related or true periapical radiolucency, which means that the radiolucency denotes a true radiolucency, that is the shadow is in contact with the apex of the teeth. These shadows cannot be shifted and will not be shifted from the periapical region in case if you take another radiograph. That is why it is called as true periapical radiolucencies. Now, moving on to each lesions, first we have to understand the pulpal or pulpo-periapical radiolucencies, as these are the common endodontic lesions that are associated or which we come across in a regular dental practice. So, as these lesions are produced by the inflammatory products from dead or injured pulp. So, the first and foremost lesion or entity to be formed from a carious tooth is the periapical granuloma. So the change, what we have to appreciate from a radiograph is that whether the lamina dura is intact or how far the radiolucency is present and what is the dimension of the radiolucency that occurs seen on the radiograph. On radiographic examination for a periapical granuloma lesion, the radiolucency will be at the apex of the tooth involved, and it will be well circumscribed radiolucency as well. Sometimes it might be surrounded with a radio-opaque rim or border. The involved teeth always will have a deep caries or a deep restoration. So this is how we identify a periapical granuloma on a radiograph. And the size of the lesion also to be taken consideration. This is how the lesion will look, and it is always lesser than 1 centimeter in diameter. So now moving into the periapical cyst, which is the second most common pulpo-periapical lesion. The periapical cyst, it has to be originated from the either pre-existing periapical granuloma, that is, the inflammatory reaction tend to proliferate and increase in size. As the cyst enlarges due to inflammatory conditions products, the pressure will be exerted onto the walls of the bone, and then that will lead to enlargement of the cyst that induces osteoclastic process and resorption of the bone at the periphery of the cyst. So radiographically, when we see, we can find a well-defined radiolucency at the involved teeth, and the tooth of interest will be non-vital, and then the measurement of the radiolucency at the apex of the teeth will be around mostly greater than 1.6 centimeter or more in diameter. Perhaps when the cyst or the radiolucency, which is greater than 1.6 centimeter, is always considered, and the teeth with a non-vitality always to be considered as a periapical cyst. So there is another lesion which will look similar to radicular cyst, which is often known as the apical scar. which is nothing but a long-standing periapical abscess would have caused a fibrous reaction in the bone. So whenever we see an RCT treated teeth, a well endodontically treated teeth with the peripheral seal is completely sealed, then and the tooth is asymptomatic, always we have to consider it for apical scar. So in an apical scar, although the lesion will look like a periapical cyst, but here it is already treated by endodontic. So endodontically treated teeth with a radiolucency at the periapical region where the margin, where the apex is completely sealed will indicate that to be an apical scar, which is nothing but a fibrous tissue rather than a bone formation. So, and this radiolucency, as in days goes by, it will heal. And this radiolucency will always be in the same site, or sometimes it will be a reduction in size of this radiolucency can be seen in other when we take a repeated radiographs. So as such, there is no treatment required for such apical scar, provided the tooth should be asymptomatic as well. The endodontic should be treated endodontically well. Moving to the next commonest radiolucency, which we see is the periapical abscess. Periapical abscess, which clinically the acute onset, there will not be much radiographic changes, but a long-standing and a chronic lesion will have radiolucency when we take a radiograph. So this occurs, why it occurs is because of a secondary abscess. Okay. In case of, as I said, in acute infection, there won't be much radiographic changes. But in case of a chronic abscess, the radiolucency will be evident in the involved tooth, and the tooth will have a dental caries, and the tooth will be sensitive to percussion as well. The tooth will become non-vital. And here, the radiolucency, at the margins of the radiolucency, you can see that there is raggedness and the margin is ill-defined. So that indicates that this is a periapical abscess, which on terms in long-standing lesion, again, if the periapical abscess is not treated, it will end up in spread of infection, which we call it as space abscess or dental-alveolar abscess. So when this long-standing periapical abscess continues to be not treated, it ends up in osteomyelitis. As we know, osteomyelitis is inflammation of the bone as well as the bone marrow spaces. So similar to acute periapical abscess, the acute osteomyelitis will also not show any changes in the radiographs, only in the acute condition. Because here, in the acute cases, the infection spread is rapid and the bone resorption has not started. So the radiolucency will not be seen. Whereas in a chronic osteomyelitis, where the low-grade infection and if left untreated causes the destruction of the bone, and thereby we will see 4 radiographic changes. In the early stage of osteomyelitis, there will be completely radiolucency will be seen at the periapical region of the involved tooth. That will be the early stage, followed by the bone reaction. Then it becomes a dead bone or necrosis of the bone will lead to formation of a radiopaque foci beneath the periapical region. So that will be the second radiographic changes. That is, it will have a mixed radiopaque and radiolucency. Another third stage of radiographic appearance will it become a complete radioopacity, and the fourth stage it will become proliferative periosteitis. So in the acute case or in the chronic long-standing stage, the first stage of radiographic evidence will be complete radiolucency seen at the periapical region of the involved teeth. And this radiolucency, you can see the borders to be ill-defined and ragged, which indicates that this radiolucency or the infection is spreading through the bone marrow and involving the bone marrow channels, and bone marrow space is getting involved. So that is the early stage of osteomyelitis, where the infection is spreading to the marrow spaces and the channels in the bone. So these are the few commonest pulpal or involved pulpoperiapical lesions which we come across in our dental practice. So there is another one which is known as the residual cyst, where that will also be mimicking a periapical cyst. But here this cyst is arised because of the after extraction, if the periapical cyst is not removed or annihilated completely, it will leave behind a healed socket. Beneath that, you can find a complete radiolucent area. So that is termed as residual cyst. So we can find a residual cyst after extraction. The teeth is not involved, and it is set below the periapical region. So this will indicate that there is no teeth and the cyst is not removed. So that will indicate that it is a residual cyst. Now, there are other lesions other than pulpal involvement or pulpoperiapical lesions, and those are called as the etiology might be from the non-pulpal origin. That is, the pulp is not directly involved, but the radiolucency will be seen in the periapical region and will produce a radiolucency at the periapical region when we take a radiograph. So such lesions are classified under non-pulpal region origin. So under which the first and foremost dysplasia or the first and foremost lesion which we have to think is the periapical cemental dysplasia. Here in this lesion, it is a fibro-osseous lesion, and this radiographically, when we see this, is also termed as a reactive lesion. So periapical cemental dysplasia is one among the type of fibro-osseous lesion, which is a reactive lesion, which arises from the periodontal ligament space. So early stage will appear as radiolucency at the periapical region. So why this has happened is, this is due to the osteolytic fibroblastic activity seen at the periphery of the teeth, and there are no calcifications will be seen. So once this early stage of PCOD, PCD, periapical cemental dysplasia, the radiolucency will be complete radiolucency seen at the periapical region of the tooth. Once this periapical cemental dysplasia becomes mature, this radiolucency will be changed into radioopacity. So this radiolucency, radiographically when we see, it will appear with well-defined borders, and the teeth will always be vital, which is a key feature when we diagnose with the pulpal origin lesions. So in a non-pulpal origin, the tooth involved will be vital and the lamina dura will be intact, and here the lesions can be either isolated radiolucency or it can be multiple radiolucency seen at the periapical region. Mostly it occurs in the anterior mandible in the incisor region. And this can be either solitary or multiple radiolucencies at the periapical region. And this looks like cyst, but it can be easily diagnosed. And this periapical radiolucencies will not exceed 1 centimeter in diameter, unlike the granuloma or abscess. So here, with these features, we can easily diagnose it is periapical cemental dysplasia. And when we see for the long-standing early lesion of periapical cemental dysplasia, the root tip will appear like a sharpened pencil. So that was one clinical feature or radiographic feature how we can diagnose it to be periapical cemental dysplasia. So another non-pulpal origin which mimics the periapical cemental or which mimics that periapical radiolucency will be like is called as traumatic bone cyst. So traumatic bone cyst will arise in a patient who is young age, and who gives a history of trauma. So in those case conditions, we can see again a radiolucency appearing at the periapical margin or the periapical region of the tooth. So traumatic bone cyst, that is why it has been considered here in the periapical radiolucency. So what we know, so in this traumatic bone cyst, what we can see is the radiolucency will be intact and it will be involving a wider area, whichever the tooth was involved with a history of trauma. Beneath the tooth in the periapical region, there will be a complete radiolucency, and the teeth will be vital. In the lamina dura, when we see, it will be intact. and there will not be any root resorptions. And one other key feature which we identify it to be a traumatic bone cyst is these radiolucency, when it passes between when it involves a multiple teeth, and when it passes between the teeth, always gives a scalloping pattern in the radiograph. So this will identify it to be a traumatic bone cyst rather than a periapical bone cyst. So always in a traumatic bone cyst, since the size of the lesion is larger, it will be greater than always 1 centimeter, and always there will be scalloping of margin of the radiolucency, and it has to be correlated along with the other clinical features. So another example which is similar to periapical cyst or periapical radiolucency is aneurysmal bone cyst. So aneurysmal bone cyst is a developmental, it's a hematological or disorder, so that, but still it will be considered here because it gives a radiolucent appearance beneath the periapical region. So it will give a multilocular pattern, but there will not be any scalloping between the roots, but still we can diagnose it from the aspiration fluid, as well the multilocular nature of this aneurysmal bone cyst. So these are the few lesions which can be considered as either pulpal origin and non-pulpal origin. So there are few other lesions being classified as rarities, although these lesions also mimic or give a periapical radiolucency in their early stage. So under which few tumors, like there are malignant tumors like osteosarcoma, adenoid cystic carcinoma, all those are considered as rarities because they give or they mimic similar radiolucent appearance at the apex of the teeth. So under which we have taken only the ameloblastoma. Commonest one is ameloblastoma and odontogenic myxoma, which indeed will be seen sometimes in the early lesion, which gives a unilocular appearance beneath the apex of the teeth. So in that case, it is to be considered, it should not be neglected, but and should be considered for the possibility of early stage of ameloblastoma. Here the teeth always in the early stage also, since it is origin from the cell rest of enamel organ, and there will not be much clinical signs, but however the vitality test can be done, and as well the widening or the expansion of the cyst or expansion of the tumor should be considered clinically as well. The radiolucency will have sometimes the internal trabeculations. With that and the root resorption will be the key feature to identify that to be a odontogenic tumor rather than any other pulpal related periapical radiolucency. So this is one commonest ameloblastoma case or early stage where we cannot miss out. Okay? And the teeth will always be, there will be drifting or tipping of the teeth. Next one is the odontogenic myxoma. This also is an odontogenic tumor of origin, but here also the radiolucency, we can make out that it is spread along the margins of the teeth, and also the multilocular pattern or honeycomb pattern can be well appreciated, and always the teeth will be displaced from its position, and there will be always root resorption. So these are the few rarities which also, even though they mimic to be periapical radiolucency, but we can still diagnose it to be odontogenic tumor. The cause can be odontogenic tumors. Whereas in other carcinomas like metastatic carcinomas here or osteosarcoma, where you can see the periodontal ligament space will be uniformly band like widening will be seen in, and it will involve multiple teeth. So with that also we can diagnose it to be other malignant tumor. So these are the few lesions which we have taught. And so to summarize this lesions, so it is imperative for us to understand the radiographic features which is caused due to the bone defect, and can not only be due to caries as seen in this picture, it can also be due to any other pathologies related. It can be either to systemic disease like hyperthyroidism, which can also cause a periapical radiolucency. So and other early lesions like ameloblastoma or odontogenic myxoma also will appear in the radiograph in the periapical region. So early diagnosis of these lesions will aid us in proper diagnosis and management of this lesions. So, however, the points to be taken into consideration will be the radiolucency size, the vitality of the tooth, the expansion pattern of the tooth of the radiolucency, as well whether the border is well defined or ill defined, the corticated margin, the location of the radiolucency appearing on the radiograph. All these features will help us or will aid us to avoid misdiagnosis and will help us to diagnose the lesion at the earliest. Thereby, we can properly manage the condition. Thank you.